Right, I think we do have minutes. We started late, so we've got a few minutes if there are any burning questions. Number 3.
Thank you. Question from Bob Lee, a trainee from Royal North Shore Hospital, Sydney, Australia. In this current plethora of treatment options, what is the role of ovarian suppression? And if there is a role, where does it fit in your treatment algorithm and clinical trial design?
That's a very good question. We unfortunately always do concentrate in both the studies and the setting on postmenopausal breast cancer. Steve, I may just ask you as to what you think is, because I think for a premenopausal patient presenting with metastatic disease, ovarian suppression is a very important component.
It is. There's a fairly old trial coming out that's been published quite a few years ago that the combination of an LHRH plus TAM was superior in survival than either alone. So my practice is to basically, very similar to prostate cancer, block them, ovarian ablate them, and then never take them off of it, whether it's medical or surgical.
Yep. Number 2.
Andrew Visioli from Kent in the UK. With everolimus, when do you think it's time to start using? Do you think at this stage in metastatic breast cancer, if a patient is already on exemestane and responding, not progressing at least, stable, would you now, in the present evidence, start everolimus, or would you wait for the cancer to progress?
I think if they're responding to their endocrine therapy, I wouldn't add everolimus in, because there'll be a cohort of patients that are getting an endocrine response, and you're not necessarily going to make that dramatically better. In the Bolero 2 trial, the response rates in terms of objective response rates to everolimus to exemestane were very low. So if you're lucky enough to be in that group, I don't think you're necessarily going to do any better. I think it's an option for when the patient is progressing on their aromatase inhibitor therapy. I don't know if colleagues agree with that. But I wouldn't add it in if your patient is responding, Andrew. 6.
A patient who has been on extended hormonal adjuvant therapy, who developed bone metastasis after, say, an aromatase inhibitor, would it be sufficient to put the patient just on fulvestrant, or should you be adding something else to the treatment? So the patient basically has got tamoxifen for 5 years, and after which the patient has got aromatase inhibitor for another few years before the patient develops bone metastasis. At this point, what will be the ideal treatment?
Well, I think, as I tried to outline in my talk, ideal meaning what is your endpoint here and what's most available to you and your patient in balancing out toxicity. So I don't think it's wrong to start with the 500 milligram dose of fulvestrant, but likewise, this patient could have, been eligible for Bolero 2. I think the fulvestrant alone probably has a better safety, side effect profile. So if the patient is minimally symptomatic, bone only, then it's not unreasonable to use fulvestrant. And about 15% of people on Bolero 2 had that prior to going on to everolimus and exemestane.
In a patient who is who are a case of luminal B, when the patient progresses on the AI, would it be what would be the best strategy? Whether you use mTOR or are you using an HER2 to inhibit the HER2 receptors?
Well, oops. I mean, I think if you haven't got evidence that they've got HER2 expression, then the evidence would not support adding that in.
Well, this is luminal B.
Yeah, but even luminal B, I mean, because, I think the evidence that we've seen with HER2 negative, yes, in a significant number of luminal Bs may have HER2, but I think you've got to document that. So there is some evidence of conversion to HER2, not in many, so you might want to biopsy to see if that's what you're dealing with. I think you might still be better to go in that situation to the everolimus combination, based on the fact that that is improving against further endocrine therapy, and whether your luminal B is just telling you that there are more signaling pathways going on. Let's wait and see the data tomorrow from the Bolero-2 genomic analysis to see if that helps us. Number 5?
Yeah, the Bolero-2 trial give information in postmenopausal women, right?
Yeah.
But we have a lot of premenopausal patients. What do you think to make and complete a blockage in the estrogen way and giving him everolimus in that patients, adding an aromatase inhibitor?
Well, I mean, the issue, I guess, is that at least based in adjuvant trials, there is some concern whether an LHRH plus an AI is sufficient to really replicate what a postmenopausal woman's estrogen levels would be, who's gone into natural menopause and then gets an aromatase inhibitor. To be frank, my practice has been if a patient tolerates an LHRH agonist, a premenopausal tolerates an LHRH to simulate the postmenopausal state, I generally recommend surgical oophorectomy, and she's basically postmenopausal, and treat them like, because as Stephen said, the vast majority of the trials are in postmenopausal, documented postmenopausal women. I don't know your other thoughts, Stephen, if you had.
No, I think that's appropriate. I think your first line option would be to render a postmenopausal scenario, because all of the emerging evidence is that your therapeutics and what else you add in will work better in a situation of low estrogen or estrogen blockade.
Thank you.
Okay, I think we're at time, so we'll conclude that. Thank you for hanging around. I hope you get a bus home. Okay.